Several years ago, the Society for Vascular Surgery decided to put together a video archive interviewing leaders and innovators in vascular surgery so that the interviews would be available for others, younger people, to look at and understand the history of the field of vascular surgery and the society itself. And today, I'm here with Dr. James Yao in San Francisco at the SVS meeting, and we're going to be talking with Dr. James Stanley. Hello, Jim.
Hello.
Jim has been a very distinguished surgeon at the University of Michigan for his training and all through his career, and is here to talk about that. So you grew up in Michigan, went to high school in East Lansing.
I'm a Michigan guy from the beginning until now. Spent a couple years in the service and 1 year during an internship, Philadelphia, but I've been pretty much surrounded by the Great Lakes my entire life. Happy times. I grew up in the mid part of the last century, sort of the happy days, the time when if you worked hard, got reasonable sleep, and played hard, you didn't get in trouble. It was a very, very different community. You didn't lock your houses at night. You didn't lock your cars at work. All the political unrest and disobedience and sexual freedom and drug culture just wasn't there when I was growing up. That's all waited until I got out of college and sort of let loose. But it was a very, very unique time. A lot of important people, I think, had their roots easily planted in those days. A little bit harder for young people today to get ahead, do the things that they want. But those were happy times. Never had much disappointment in my whole life. Coming of age was easy and actually a lot of fun.
Were your parents involved in medicine?
No, it's interesting. My mother and father had very different roots. My father grew up on a farm in southern Ohio. My mother grew up in Toledo. Her father was a pharmacist and had 3 drugstores and fairly affluent. They drove an Auburn car, which was like probably driving a Rolls Royce in this day and age. And my father ended up in sales. By the time my father was in his late 20s, he got involved with municipal securities. And by the time I came on the scene, my parents were both born in 1900, and I was born in the late 30s. By the time I came on the scene, he was involved with banking and bond market. My mother was a stay-at-home mom. She had gone to finishing school out in Boston, and both of them were pretty intellectually stimulating, but neither one of them were in medicine. I had a brother 10 years older. I think I was an afterthought. I think I was one of the last hurrahs of my parents. This is when, to get pregnant, you either counted back 14 days from your next predicted cycle, or you would, take your temperature. Pretty bad arithmetic. So I may have been an arithmetic mistake, but my brother, who was 10 years older, went to art school, and it sort of made anything I was going to do just fine with my parents. I actually started off in engineering school before I went to medicine. So I had a supportive family, supportive parents. My brother took the heat off me a little bit for having to be productive in my life.
So you went to engineering school at the University of Michigan, and then how did you decide to apply to medical school?
When I started off in engineering school, the first day, the dean came in and said, everybody stand up and take a look at the person on either side of you at the end of 4 years. Only one of you will be left. And I remember I was with 2 of my high school classmates, and we were all committed to going in engineering. This was the time of Sputnik, and if you could think and had anywhere as a scientific mind, this was where to be. And I had actually wanted to go into automotive engineering. I rebuilt a 1932 Plymouth Coupe with a rumble seat when I was a junior and senior in high school, and read Walter P. Chrysler's autobiography, and I wanted to get my mechanical engineering degree from Michigan. I wanted to go to MIT and get a master's in metallurgical engineering. So I was very programmed into engineering. And it's interesting, the thing that swayed me was watching Tom Dooley, who was a missionary physician in Southeast Asia. He wrote a couple books, Promises to Keep, and The Night They Burned the Mountain. And it was very moving. And I always had a commitment to really do something that would make a difference. And it was like turning a light off or turning the light on, depending on whether you're leaving engineering or going into something else. So my new mistress was pre-med rather than this commitment to engineering. But it happened with the stroke of one thing, and I never looked back. And I was in the top 10% of my engineering school class, something I never obtained when I was a pre-med student. I enjoyed the college life, and I must say, when I interview young people today, I'm glad I'm not in the same market, because I doubt that I would have gotten into medical school, given my academic record as a pre-med student.
So then the obvious place to go to medical school was the University of Michigan.
Well, at that time, I think people tended not to look to either coast or wherever, and Michigan had a very good medical school, and they had all the things that I thought I wanted to have in a career, both theoretic medicine and practical clinical care. So I was very happy when I got accepted there.
Who were the people there that got you interested in going into surgery as a field?
Well, it's interesting. I had been accepted my senior year into the internal medicine program, and I had wanted to either be a rheumatologist or an oncologist. And I was very, very intent on that. Did my internship at Philadelphia General. And again, it was one of these epiphanies. I took care of, the first month I was there, took care of a patient that had a malignant arrhythmia, and we stayed up all night with him with IV quinidine. Darn near killed him. And I was paged about 2 months later to come back and see him in the clinic. And when I came back to see him in the clinic, he was taking his DIG 3 times a day and taking his quinidine once a day, and his DIG toxic. And I liked everything in medical school. I liked pediatrics, I liked dermatology, I liked surgery. But at that point I just said, whatever I do, I want it to be finite. I'd like to have my patient not totally goof everything up. And this patient goofed everything up. And as much as I enjoy differential diagnosis, the idea of treating somebody and having them not follow my instructions sort of turned the light off. And that's really why I made a decision to go into surgery. I had some phenomenal mentors in medical school to make that decision easier. Bill DeWeese, Jim DeWeese's brother, was on our faculty when I was a student. And Dr. DeWeese did the first aorta renal bypass in the world. He had the DeWeese clip. He was one of the first to show interruption of the cava short of ligating it for pulmonary emboli. And people were doing that all the time for septic emboli, but not for just bad DVT with an embolus. And he actually did the first aortic coronary bypass in an animal way before cardiac surgeons and the rest of the world were doing it. So he was very talented. He looked like an English professor at some small college. He was not a bravado surgeon by any stroke of the imagination, and was a good role model for me. So he probably was the one that encouraged me most to go into surgery. I spent time on his service as a senior student just trying to balance out my understanding of breast disease and gallbladder disease that I thought I needed was going to be an internist. And I think a lot of the surgical mentality stuck with me. But he was my primary mentor, if you will, during medical school.
And so then in your surgical residency at the University of Michigan, who were the main influences?
Well, probably 3 people. Bill Fry, certainly he was the head of the general surgery training program. And Bill was a doctor's doctor, had a lot of intuition in the operating room that 99.9% of the time was right on target. And Bill gave me a great deal of support in my own early academic career. I had 11 months during the 4 years out of my 5-year. My first year was this internship in Philadelphia, but when I came back to Michigan, I had 4 years of surgery. I had 11 months with Dr. Child, who I think was the most masterful general surgeon I've ever operated with or seen operate. He did portacable shunts without a bovie and without a suction machine, and didn't have a mess on the operating table. He was very meticulous. And the other person was Cal Ernst, who was a few years ahead of me. Cal would get after me, which would probably be viewed as abusive behavior, but he was like a brother. And he helped me a great deal with writing. He used to argue with me. I think I've never written a perfect paper, but I came close. I had a 2.5-page paper showing you could put little amyloid clips on renal arteries. It was published in SGNO way back in the 70s. We argued over every damn sentence in that paper before it got submitted. And you know, it probably was better, and I learned to think before I put something down on paper, rather than putting it down on paper and then having to defend it or modify it later on. So he was a pretty important influence to me. We had completely different personalities, but he was a lot of fun to work with. And so those three people really were my mentors.
And then over the years, you've spent a lot of time working on other projects with Cal Ernst, particularly the current therapy and vascular surgery book that the two of you edited, known to some as Ernst and Stanley.
Well, Cal and I sort of were not going to be in the publishing business, but what happened was Emmerich Szilagyi, who was the functioning editor of the Journal of Vascular Surgery, decided he needed an associate editor, better known as a lackey, and I was the one that he asked. And I remember I didn't know whether to be happy I was being invited or to be challenged. Emmerich, we had about 400 submissions a year. Emmerich expected me to have a typed evaluation of every one of those papers. And he would say things like, Jim, you know, we need to meet once a month and go over the submissions that we're going to advance to the publisher. And you know, some people think it's shorter from Ann Arbor to Detroit than Detroit to Ann Arbor. Actually, it's much shorter from Ann Arbor to Detroit, so why don't we meet in my office? And you know, we used to meet around this 12-foot table at Henry Ford Hospital. And Cal and I think, started thinking alike, namely to defend ourselves against Emmerich trying to tell us what we needed to think. And shortly after Emmerich stepped down, we were asked to be co-editors of the journal. So we had 6 years of being co-editor of the journal. And subsequent to that, John Cameron had published the Current Therapy in Surgery, which was a very nice compendium, very short sequences of topics. And the question came from the publisher if we wouldn't like to do the same thing for vascular surgery, and that was really, to be quite honest, was a no-brainer for us. So we ended up publishing, you know, the first edition of Current Therapy with no references. We wanted it to have a lot of topics. We wanted it to be practical for the clinician. This was not a research enterprise. And we actually had a lot of fun doing that. And that was the first time, at least in our specialty, anybody had put together that kind of a small vignette kind of textbook.
Right, and so that came out in 1987.
Yes.
And then the 5th edition is just about ready to come out at this point.
The 5th edition with 307 chapters. Some of my closest friends who I've felt like I'm chasing cats down the hallway to get them to get things done on time and all, but that's just about done. And over half of those chapters are off at the printer right now, and the other half will be done in another month.
So then how did you decide to focus your career on vascular surgery? You had Dr. Fry and Dr. Child, and how else? How did
I mean, the pecking order is so different today, especially with endoluminal interventions and especially with the 05 program. So as a general surgeon, there was a limited number of vascular cases, even though our institution is pretty rich in that, in general terms, in that area. And I had never done a coleotomy. I had never made an incision through the abdominal wall. And a patient presented to the service that had a splenic artery aneurysm on a flat plate. Typical signet ring, curvilinear with a little line on the inside of it. And they said, you know, Jimmy, here's a case for you. You get to actually make an incision in the abdomen. You're not going to take out a gallbladder and goof up the biliary tract. You're just going to go after this, take out the spleen. It's a chip shot. And so I made this, I was quite happy about this. Made my incision, got in there, and this was a fricking calcified epiploic appendage. The epiploic appendage had twisted on itself, had become necrotic, and was stuck to the capsule of the spleen, which I was going to cut off. I picked it up and it fell off the spleen. And I handed it off the table and closed up the abdomen, and I mean, I was happy I had made an incision in the belly. But you know, I was a little bit taken back that none of us had a clue that this wasn't a splenic artery aneurysm. And so I decided I would look at the institutional experience with splenic aneurysms to find out how we had made the diagnoses before, hoping we had been a little bit better. And at that time, there was a paper out of Mayo Clinic, in fact, the largest collection of splenic aneurysms, 80% rupture rate. These were viewed as lethal aneurysms. And when I looked at our experience, we had had no ruptures. And, this is just when imaging, not ultrasound, but a lot of arteriography was coming into the forefront. So that was my beginning to review that. And I actually published a paper, my first paper. The first sentence was, flank neck artery aneurysms are more common than previously thought. My wife can remember my saying that 100 times in the hotel room before I plopped down to give out my 10-minute talk at the vascular meetings. But that was my start, and it was easy because at that time I had a mechanical interest in vascular disease. I had a pretty good background in cell biology, and there was just an open, fertile field. No one was doing really tight research, if you will, related to vascular disease.
At that point, people didn't do formal vascular fellowships.
No.
Yeah. How did you become interested in operating on children with various vascular problems? Renal vascular hypertension particularly, and also aneurysms.
Walt, I've been very fortunate. I've through the history of Dr. Deweese, Dr. Fry, and Callers, we were one of the centers that had a lot of patients referred to us. They weren't great in quantity until about the time I finished my residency and joined the faculty. And we had all comers. I mean, I've had good fortune to operate on a retired secretary of the World Bank with an aorta renal bypass from Washington, retired Surgeon General who retired in Hawaii, did an aorta renal endarterectomy for malignant hypertension. So we had sort of this cachet that we had the expertise. We had wonderful radiologists for imaging, and a number of us did a lot. I think I did one open renal a week, probably for 5 or 6 years. And in that, we're an occasional child, and they're challenging. They are not like a checkers game, they're like a chess game, namely because many of them have central aortic narrowings in addition to renal artery narrowings and mesenteric. And this all sort of a perfect storm, a perfect opportunity. The retired head of pediatric radiology at our children's hospital had a dominant interest in neurofibromatosis, NF1. And he was really interested in skeletal abnormalities. An occasional child would have an nephroblastoma and be hypertensive. And when they went back and looked at this huge cadre of children, a number of them were hypertensive, and imaging, the perfect part of this opportunity, was just coming to the forefront. So we could get studies of the arterial anatomy, and many of these children had renal artery narrowings. And that ended up being something next door that all of a sudden we were treating. There had been a case series reported by Dr. Fry of 12 cases, 3 of whom had had malignant hypertension and had a malignant encephalopathy and were retarded mentally. They were not able to function at a normal intellectual level. And nobody at that time was taking blood pressures in well baby clinics. And 3 people had this, and it changed the way well babies' blood pressures were assessed. People used to always feel a femoral and a radial pulse, and if there was a leg, they'd worry about an isthmic cohort. Nobody ever thought about renal artery disease because they didn't take blood pressures. But that sort of changed it, and when that happened, because of this paper, we had a lot of children referred to us. And I think our case number, it's a boutique practice. On the other hand, it's over 180 children now, and in the next 4.5 weeks, I have 7 children scheduled for surgery at our children's hospital. And we've had kids from every continent other than Antarctica, from all around sent to us. And they're hard cases, and I think most vascular surgeons, unless they are doing transplants in children and the like, probably don't want to take this on. They're 6-8 hours, interrupted stitches, and they don't always go well if you don't have the expertise. Not so much in tying square knots, but making decisions on you're going to reconstruct the mesenteric vessels first for the right kidney or the left kidney, or patch, or do a thoracoabdominal bypass for the aortic, and then do the renals. They end up being much more of an intellectual enterprise than they do a surgical operative enterprise.
There are a couple of interesting technical ideas that you have contributed. One is the idea of using the saphenous vein and using one of the branches for a heel to come off the aorta.
Yeah.
Where does that idea come from?
I have no idea.
Is it your own, or is it one that you were taught by
Well,
Dr. Child?
I'm sure it was one of my own, and the reason is when I was the third-year resident, I reviewed 100 consecutive aortic and renal bypass grafts, almost all of which were in adults, and we had a funny little line at the beginning of these, and I had no idea what it was, but the reason it happened is because people didn't spatulate the vein graft or use a branch to create sort of a corral patch, if you will. And so, I just said we need to do this. I mean, I'll tell you, when I was editor of the journal, I literally read 400 manuscripts. I mean, this was like having another job every year. And I'd read something, somebody tells you the sky's really purple, it's not blue, and you realize that you don't want to tell anybody where you read it, but once you see something, it's pretty hard to ignore it, and you can't. It would be you'd be breaking every rule of integrity if you took some idea of somebody else's and used it. So one of the difficulties when the Gore grafts first came out to do an aortic anastomosis with a Gore graft was getting the needle through the graft and then having to turn your arm or twist your arm to get it into the aorta. And someone in Western Europe had taken the end of the Gore graft and folded it back probably 1 millimeter or 2 millimeters. So all you had to do was get your needle close to the groove and push it, and you had a good bite of the Gore graft. And I remember the first 2 or 3 times I did that, people would say, "Where did you learn that?" And I knew where I learned it, but I didn't want to say. But it's pretty hard to ignore something that makes a difference. Or using the superior thyroid artery is a patch for carotids. I normally use a prosthetic or a bovine patch or something in this day and age. But before we were doing that, I remember one time with somebody had a huge superior thyroid artery, and I was helping the fellow do a case, and I asked for a couple snaps, and I took out the superior thyroid. I'm sure somebody was ready to call 911 and have me hauled away. But by the time you open up a 3 millimeter graft, you've got a centimeter wide patch, and it's arterial patch. And so I have no idea. But I'm sure that no one at my institution was ever doing it before we started using the branch to get a bigger orifice.
Another technique that some of us have wondered about is the use of the transverse abdominal incision at the University of Michigan.
Yeah.
And where that came from.
That came from Dr. Collar, who felt that if you did that, you would have less risk of a hernia forming. Lord only knows what kind of suture they were closing abdominal walls with when Dr. Collar was doing this. But they clearly were not. They were probably silk or something that was going to be there for a short while. The paper was written by Bill Deweese and Bill Fry at the Fret Shift honoring Dr. Collar's retirement. It was published in Annals of Surgery, showing the mathematical advantages to an infraumbilical transverse incision to get both at the iliac vessels and up at the aortic hiatus if you had to do some extensive procedure. The follow-up of those patients were that a fair number of them had hernias, and those that didn't have hernias, when they transected the lateral muscles, the abdominal wall, internal and external oblique, they had a weakness, so people would have a little pouch sticking out there. It wasn't really a hernia, but it was a weak abdominal wall. But I must say that incision based with medial visceral rotation to get at the aorta with the origins of the renal arteries is like doing bench surgery. And we still favor that incision. You can do it with a vertical incision, but it's a little more of a struggle, and you have to hold your instruments almost perpendicular to the table rather than parallel with the table. So sewing, it can be a little bit awkward if you're doing a real small vessel reconstruction. But I wouldn't overly defend the transverse incision. I'm sure half our trainees that are forced into doing that when they leave probably make up and down incisions. They work just as well.
You've had the opportunity to work with a number of very outstanding younger people at the U of M. Do you want to talk about some of your colleagues there?
Trainees and the like?
Trainees and faculty members, yeah, and all sorts of talented
people. Well, I think most of us that have been lucky enough to have some leadership role, especially in the Society of Vascular Surgery, all have colleagues who every time you're at a meeting, they're looking over your shoulder to see who else they can talk to move up the chain. And I would say half of them, well-intended, talk about the giants on whose shoulders they stand. It's sort of a cliche. And to be quite frank with you, I think most people that are really, really productive and really good, they may have had some mentors that said, hop up on my shoulder, but most of them get there because they have a lot of bright young people lifting them up. And it's always been my philosophy, if I can find some smart resident, you make rounds, you're talking about some respirator thing, and you start spouting off, and the third-year medical student who you don't know but had a PhD in pulmonary physiology sort of drops it down on the table about what's really going on. And to be quite honest with you, I think that's the way the whole profession will advance, is to take sort of the unencumbered, naive mind. So we've had this litany of really bright young people, and I've had, I'm not a PhD scientist, but we've had 3 people get PhDs in our lab. And I mean, they're really bright. And we've had a lot of other people who've made what I think tremendous contributions. And it started when they were trainees. And they've made my life more exciting, and they've actually made my life much more productive. I mean, they do the hard first drafts. They've got the ideas and say, is it a pipe dream? And I'll say, we got the money, go for it. It may be viewed as hobby research, but every once in a while it turns out to be a more important thing than the NIH grants that I might have. And so we've had the resources and bright young people, and you just give them some freedom. But there have been some tremendous people. I mean, Linda Graham, who trained with Jimmy Yao and John Bergen at Northwestern, phenomenal intellect. First woman president of the Society of University Surgeons. Still doing active research. Her husband's a molecular biologist at Cleveland now. Raj Sakar got his PhD in our lab on nitric oxide, looking at endothelial and smooth muscle migration. I mean, just a lot of people. I mean, just one after another. If I started listing them, I'm sure I would miss some ones that would probably be very unforgiving.
Jim, thanks for coming. We know each other for a long time. It's really great to have you in this program. You are the number 57 surgeon that we are interviewing. The American Board of Vascular Surgery has seldom mentioned. And I think it's a very important in our history. And I would like you, as a leader of the group who advocate American Board of Surgery, Vascular Surgery, to give us some perspective about how it formed, what are your objectives. Just tell us from the beginning to the end so we can have that in our history.
Well, invitation to talk about that is something, I have 2 file drawers, lateral file drawers, full of correspondence that occurred back in the late 1980s, early 1990s, related to trying to define independence for vascular surgery. I just finished reading a memoir that I would suggest people ought to look at by James Watson, who, wrote the double helix, and along with Crick, Francis Crick discovered the anatomic structure, if you will, of DNA. And the title of it is Avoid Boring People. And he starts off in the introduction saying, I've got a lot of papers at Harvard, where he had a faculty position for a while, a lot more at Cold Springs Harbor. And he says, I'm sure somebody's going to come along and write what I was all about sometime in the future. And he said, I just decided maybe I ought to tell them what I was really about before they goof it up. So I would be very happy to comment about the American Board of Vascular Surgery. It was, I think, a tipping point for vascular surgery. It was very divisive outside our profession and within the vascular community. And I think that's unfortunate. I can be quite candid about some of the individuals that supported and were detractors of this idea. I mean, vascular surgery was conceived, 75, 80 years ago, and it actually was sort of born back in the early 70s when it became apparent that some people were taking really good care of patients and other people did not have the expertise based on the training probably to do some of the things that they were being asked to do in practice. And Jim DeWeese was the first to sort of take a look at how we would train people. And he was involved with the American Heart Association at that time and put together a proposal for training people to do vascular surgery. Cardiac surgery was already on its own way. And at that time he did that, the American Board of Surgery said, we do not care to move on this. This is a turf issue. And it actually was probably a bigger turf issue between general surgeons doing vascular surgery and the cardiac surgeons who were doing vascular surgery than anybody else. And a few years later, Jim DeWeese, along really with the leadership of Jack Wiley, put together a guidelines for training, and they had this PEAK program, Program Evaluation Endorsement Committee. And the American Board of Surgery really did not want to get involved with this at that time. And they started doing that, and that was back in the early 1980s. And by 1984, it was clear that young people finishing general surgery who wanted to do vascular surgery were signing up for these unofficially approved programs that had no ACGME, no residency review committee or anything like that, but strictly done with Jesse Thompson and Emmerich Zalagi and Jim DeWeese and Jack Wiley, this group that really were very adamant on their own time and their own support to go out and look at programs and make suggestions. And at that point, the board said, we really ought to do something. So they went ahead and they said, we agree we need to have training criteria. In 1982, they gave the first exam to 14 wonderful members of the directorship of the American Board of Surgery, which included 2 vascular surgeons. Some trauma docs who kept saying, you're fragmenting general surgery, why in the world are we doing this? But they took the exam. They all passed, interestingly. And 2 years later, they got approval from the ABMS to have training programs approved with an RRC. And that really set the stage. They had a certificate of special qualifications, and that ended up being a bone of contention. They were very, very incensed, I think, that somebody thought they could do something better than the very good general surgeon who was well trained. And so the certificate was smaller than the regular board certificate. I mean, it became very petty. And of course, whoever suggested that met with the same kind of pettiness from the vascular community, who said, you guys are a bunch of idiots or something, you don't understand what we're trying to do. And that actually went on and on and on, and it was somewhat foolish. Because in order to sit for that exam, you had to do 100 vascular cases. You had to have some documentation that you had taken part in a big educational program, presented papers at a national meeting, and it became an elitist group. And for the majority of vascular surgeons who were not in an academic center, who were not presenting papers, it was very offensive. And the occasional person that was doing 80 cases a year was then struck with, if I want to maintain my hospital privileges in vascular, I've got to do a few more so I can be certified. And it was the wrong carrot to wave in front of people. And that was attributed to the vascular community. It wasn't the vascular community, it was members of the American Board of Surgery who did not want to let this group go too loose. Probably 4 or 5 years after that, the board decided they needed to have criteria for the number of cases a finishing general surgery resident would have in order to sit for an exam. And the first cases that were identified were 44 arterial reconstructions, which may have been fine. And if you look at the number of cases done in the aggregate pool and then divided the number of trainees, that might have happened. But the problem was some programs, like at Ann Arbor, I think our finishing residents were doing 120 arterial cases. There were some that weren't. And it was going to be hard for many, many good programs to train their general surgeons with that criteria and have any cases left over for any kind of a training fellowship. and it put about a quarter of the existing fellowships at jeopardy. Only about a quarter had enough cases to really fly with it, and the other 50% were sort of in no man's land. They varied from year to year. And at that time, Frank Vieth gave his presidential address about the evolution of vascular surgery, saying we either change or we're not going to exist, and we need to separate ourselves. And also at that time, the American Board of Surgery was having real conflict. They supported the American Board of Plastic Surgery in a lawsuit to try to prevent otolaryngology from getting a certificate of facial plastic surgery. And as it happened, I was going to the American College of Surgeons meeting where we would have a joint council meeting separate from our June meeting. And I got bumped up to first class, and this very nice gentleman sitting next to me, a green golf shirt, sweater on, yellow pants, and I pulled out some papers that and he said, "Are you a surgeon?" I said, "Yes." And he asked me what kind of surgeon I was. I said, "Well, I do vascular surgery." And out of the blue, I didn't know who he was. He said, "What do you think about the American Board of Surgery?" And I said, "Well," I said, they really are holding up pretty high standards for quality of care and training. I mean, to get the trainees there." And he said, "Well," he said, and he sort of let loose and he used some language that I wouldn't want to be quoted on, but he said, they are very turf oriented. And he said, what happened was, said I happened to have been the president of the Massachusetts chapter of the American College of Surgeons, and I invited the sitting director of the ABS to come give a pep talk to our trainees, and somebody said, "Well, how are things going with the board in general?" And he said, "Well, we're okay, except those nose pickers want to have facial plastic surgery." Well, it turns out the man I was sitting next to was Gerald Healy, who eventually became chairman of the Board of Regents of the college and was an otolaryngologist in Boston. And he was furious that anybody in a surgical profession would call somebody else sort of a derogatory. I mean, calling somebody a nose picker is not the worst thing you can call them, but it was a very derogatory term. And I got off the plane thinking, here we are trying to lower this requirement for general surgeons, and we have no audience. And at that time, Bob Smith was president of the ISCVS, and I was president of the SVS. And I said, "Bob, I don't think we're going to have an audience with the board, and we should think about having more independence so we don't have to argue our point every time there's an issue." And Bob agreed. And we then met, and it turned out that our chairman of otolaryngology had been involved with this fray that I had never heard about. I doubt that very many people had. And I asked, his name was Chuck Krause, and I said, "Chuck," this is what's happening to us. What do you suggest? And Chuck said, "Well, there are two attorneys in the country who know a lot about educational issues related to medical graduate training and postgraduate training." And he said, "I would suggest you speak to them." So Bob Smith, who's I think one of the most gentlemanly surgeons I've ever known, and I met with Bill Maloney, who was the director of the Society of Vascular Surgery, the executive director at that time, met with Thomas Rhodes, who was one of these two attorneys in Atlanta, Georgia. The other one was from Texas. And he said, "Well, you've got a long road to hoe if you think you're ever going to have independence." It turns out he had represented otolaryngology, and they were successful in their approach with this. It turns out that Tom Rhodes was a very good friend of the general counsel for the ABMS, and it was all politics, but it was very civil. So that was the topic then of my presidential address in 1997, a year after Frank Vieth's. And at that time, we incorporated the board before I got there, and there were 8 of us. Myself and Bob, who were sitting presidents, Bill Abbott and Bill Baker, who were presidents-to-be, and Frank Vieth and Jerry Goldstone, who had been presidents, and then Andy Whittemore and John Town, who were secretaries. And we met in Chicago, and we said, Tom Rhodes will incorporate our board, cost all of $125 in the state of Georgia. Do we want to do it? And none of them knew that Bob and I had gone off in this path with Bill Maloney. And we met again at O'Hare, and to a person, they said, we're way overdue. So we incorporated a board, and that was in the early fall. We announced it at the American College of Surgeons meeting to the program directors in general surgery. John Porter was the head of the program directors in vascular surgery. It talked to the director of the American College of Surgeons, and it really created a big rumpus at that point. For my presidential address, which was down the road, we solicited opinions of everybody that had a certificate. 91% of people who had their certificate said, we want to do this. In 1997, in the Journal of Vascular Surgery, we had, for better terms, a manifesto where we said we're declaring independence. It's the American Board of Vascular Surgery. It was signed by about 40 or 50 people. Yeah. All the executive officers of the SVS, all the executive officers of the North American chapter, all the officers, the program directors. And we said, you know, if the American Board of Surgery just needs to respect what we're trying to do, and we were working back from patient care. This had nothing to do with finances, had nothing to do with ego. It had to do with training people so they'd be competent vascular surgeons. And obviously that gets translated into where you practice and what you can do at a hospital. And of course, the ABMS said all we do is look at training criteria. We don't look at practice things. That's a hospital issue. Well, the reality is the yellow pages in a number of our major cities had lists of people that had their ABMS certificates in pediatrics or surgery or whatever, which is where patient care enters into it. So they were talking sort of out of both sides of their mouths. And then the outcome of that was we spent the next 4 or 5 years trying to negotiate with the board to have independence. And we finally, when we weren't getting any place, 2002, Jack Cronenwet and Frank Veith and I went to the liaison committee. We petitioned that we have a board. And we did that on the 18th of December. A few days later, we got a note saying that our petition had been declined. On December 26th, the day after Christmas, we wrote a letter to them saying there are 4 or 5 criteria to establish a board. We'd like to know where we failed. And that we wrote back saying we did not discuss these individually. You failed on global issues. We then had 6 months to appeal that, which we did to the AMA, which was a parent support of the liaison committee. And they wrote back this wonderful letter saying, each issue was never voted on. There were no minutes taken at the meeting. Therefore, we can't tell you the criteria which are now. Well, it was maddening. At that point, it was very clear that this was almost like a cartel. And we met many, many times about that. The subsequent thing that happened was the ABS realized nobody was going to go away. This was going to be a smoldering problem. And Richard Green, to his great credit, negotiated with the board then to have a 0 and 5 certificate separate from general surgery. And you know, it was so important to do that. At that time, 27% of people in general surgery training programs were women. That was the birthing ground from which we had fellows to do vascular surgery. You could never have more than 27% of people go into vascular surgery because that was the pool. And vascular surgery at that time had 20%. It's very interesting. In this day and age, with the 0-5 program, over half the trainees are women. Mm-hmm. You talk about a workforce pool that had never been allowed to take part in their profession. So it was a means of dealing with some things that just weren't quite right. And I think it's made a huge difference to our profession. And we were very fortunate to have it happen. So that's a little bit of a long song and dance of where we were with the board issues.
You have a consultant at that time. What's the name of the consultant?
We had a consultant that had been the executive director of the American Board of Emergency Medicine that was the last board to be certified. And Ben Munger was his name, PhD. And it's interesting, Ben was, again, like a quiet English professor at a small college. He was not some slam on the table kind of a loud person. He had just been given the Distinguished Service Award from the ABMS when we hired him. So he had credibility with the people who had rejected what we had wanted to do. And Ben's point was that when they tried to establish vascular emergency medicine, the issue was there were many small towns that had emergency rooms, but nobody had really been trained. Pediatrician or an internist or a surgeon would sort of take it over and build whatever they wanted. And they were absolutely rejected. I think the vote was 121 to 2 or something the first time they made an application. But whoever was the head executive director of the ABMS said, you know, why doesn't everybody go back and say, if you're a cardiologist, what training do you want to have an emergency medicine person have so they can deal with an acute MI? Or an orthopedic surgeon, what do they need to know if they want to put plaster on a Colles fracture or something like that, not some intricate spine surgery. So they came back the next year, and the total training to be in emergency medicine, if every specialty had their Gitchin, you know, and sort of shepherded these people through training, something like 14 years, at which point they said, this is crazy, and we understand we need better people. So they had approval at that time. So it, you know, Ben was very instrumental at sort of keeping us in the middle of the road.
Is that true that we have an office in Chicago?
We had an office in Chicago. We had a lot of support from many people, but, you know, as I say, it was quite divisive. And part of it was that some of the people within our own specialty felt very strongly that the most mature person was someone who had 5 years of general surgery and then had additional vascular training. Now, there's no question but what they're more mature. The problem was at that time, there were probably, out of the 70-some training programs, there were something like 15 or 16 that didn't fill. Kids were not going to do this. And you know, we needed to have a different path for people to be trained. And as I mentioned, women were not part of the equation. You could never have more than 27% of your faculty or your fellows be female, which was just foolish. It was just quite foolish. So you know, we had a lot of support and a lot of reason for this. Some people felt we were fragmenting general surgery. You know, bless their souls. I mean, if I have some serious problem, as true to Michigan as I am, if I could go to MD Anderson or Sloan, I'd be out of there in a flash for a 5% difference. Why wouldn't you drive 40 miles to have a vascular surgeon take care of you rather than staying in your hometown, you know, and have somebody do something with morbidity, mortality that's not acceptable? So there was a lot of pushback, but I think the society and people really did well. Jack Cronin was very important at helping establish the 05 program, the integrated program.
Well, I don't think we should consider that disapproval is a failure. I think what you have done, what the group have done, you know, we make the difference for us. Now we have the 05 program. We are doing all the things that's supposed to be done by vascular surgeon. So I think you guys have some positive impact on that.
I've never had a second thought, Jimmy, about the value of what we did, and I've never had any regret. I do think that we've become broad enough now that to think even, you know, we're a little bit like otolaryngology might be, or neurosurgery. We have enough expertise in little pockets of what we do. I think it's highly unlikely that anybody can do all of it. Anybody tells me that they know how to deal with complex arch reconstructions with an endograph and then can deal with some little child that's got 2 millimeter renal arteries, and by the way, they've got a bunch of vein valves that need to be dealt with. I mean, that the information is quite broad. We have enough specialists that someday, I just like in otolaryngology, you'd be a neurotologist or a head and neck cancer person or a sleep medicine doc, and there are a lot of things that I think vascular probably will morph into as time goes on, and I think patients will be the beneficiaries.
Well, I just want to change the subject a little bit. You are the editor, you were editor of the Journal of Vascular Surgery. As you know, Fogarty paper, when it first submitted, was rejected by Annual Surgery, and finally picked it up by Loyal Davis or AGNO. Parodi's paper on endovascular surgery was rejected by Journal of Vascular Surgery, not from you guys, somebody else. I won't say
it, right?
To me, this is two most significant invention in vascular surgery, and both of them were rejected. I just want to know from you, is there something wrong with the peer review system, or what happened? I mean, how could that happen? What can we do to avoid it? This is the big invention.
Well, Jimmy, I mean, I really recommend that everyone take a peek at Jim Watson's memoir of Avoid Boring People. You know, it relates to his thought process of sort of maverick thinking, renegade thinking. It resonates with me. One of my very good friends was chairman of medicine, Tachi Yamada, at our institution, became vice president of a major pharmaceutical company. Tachi just stepped down as the president of the Bill and Melinda Gates Foundation. And they give out small grants. And Tachi, when he was on our faculty, spent day and night rewriting and writing R01 grants. And I mean, I've been in the same place, academic award from NIH, R01 grants. The reality is that if you look at probably the 20 most major contributions to medical areas in the last 4 decades, none of them have been funded or have been outreaches of peer review at the NIH. And I think the same thing's true. And so the outcome of that was that Bill Gates said, if somebody's got an idea, we're not going to give 100 grand every year for 3 years or 5 years or something, but we'll give 100 grand as sort of hobby money, you know, in a derogatory, some people do that very derogatory. He didn't, to come up with ideas. They had materials they could spray in fields that insects would pick up, and then ultrasound, they were sensitized, the insects were sensitized to the ultrasound, harebrained idea, and nobody thought it would work, but it worked. And I think medicine's the same way. I mean, Juan Pradi's paper was accepted by Ramon Bruguera, and he and I, the only difference between our offices is a little thin wall right now. And Juan's been a good friend. I was not part of that decision. I have no doubt there are good ideas that don't have p-values associated with them that are observational. I mean, the first AXFEM on a patient had an MI on the table that was supposed to have an amputation. They couldn't do the amputation, so they did with local anesthesia. I mean, you know, that was game changing. So, you know, I think you have to have very intelligent people, and you have to have the resources to make mistakes. And with, you know, I mean, we've got very major labs that are quite at risk with the funding for, you know, federal funding. So you have to think about what you can invest in, and you have to think a little bit smaller and take a little more risk at times. I don't think people should have papers accepted because they've got a great track record. The paper should be accepted because it generates new knowledge, not because they got credibility. Same thing happens with other granting agencies.
One other issue I think very important for us is the woman in surgery. As you know, the medical school class, 40% or even more are female. So there will be an increase in women in surgery. What as a leader in training, what we should do to be flexible, to help them have a career, have a family, and children, raise the children, and what's your thought on that?
Oh yeah, I've viewed women being ignored by the sort of the macho surgeons that train me as being very, very foolish. So the first thing you got to do is be smart. And I'm not much of a fan of Warren Buffett, but you know, his comment is that half the workforce should be women, and it's not. I mean, that in all areas. So, you know, when Linda Graham finished your training program and joined our faculty, Linda was one of 4 people in the SVS that was female. That's crazy. And I mean, you know, that makes no sense. But on the other hand, the institutions, as I mentioned, if the only place you can get a female is through a general surgery training program and only 27% are going into general surgery, then you're never going to get more than that going into your fellowship. So I think the 05 program, like I mentioned, over half the trainees in the 05 program are women now. Mm-hmm. I can tell you, we have a third of our faculty are women. and way over half of our trainees are women at the University of Michigan. And they're there because they're the smartest people that when we had an opportunity to recruit somebody, they're the ones that were in the top. So I think it's changing dramatically, and but I think my answer is people need to just be smart and realize that there's, gender differences I don't think exist. I do think it's an issue if women have to be protected if they're going to have children, and you have to be flexible with that. But to say that we can't be flexible is just out of ignorance. I mean, that's just not true. So I have a fair amount of passion for that, Jimmy.
Yeah, we are closing to the end, and I just like to ask you, what would you tell young surgeons what they should do?
I think vascular surgery is very diverse, and I think there's, it depends whether you're interested in going out and just helping humanity. If that's your sole goal in life, get soap and vitamins and be a missionary physician someplace. I mean, really. If you've got technical abilities and a creative mind, I think vascular surgery probably offers as much as almost any other specialty to advance, the care of patients. I mean, we should all be in business to put ourselves out of business. So those of us that have been in the research arena to understand not how to treat somebody better, but how to prevent the disease, I think is wide open. I just don't think that there are very many cardiologists that eat and sleep. The cardiologists are much more interested in myocardium and genetic disorders that affect that than they are in atherosclerosis. I mean, if you think about the number of people looking at hardcore atherosclerotic disease in the vascular surgery community, there aren't very many. I mean, we may look at neointimal hyperplasia or graft surfaces, durability of stents to stay in place and all that. So I think from an academic perspective, it's wide open. From a clinical practice thing, given the patterns of the aging of society, I think it's an opportunity for people that really enjoy taking care of sick patients to do something that's valid. And I think it's still a surgical field. I mean, I think when a patient's asleep, they can't negotiate with you, and you will be better trained. And I think that discipline that goes into that is still, part of our culture. I would hate to see it become a business. The talk of RVUs and how you can support this or that, it really goes in one ear out the other if the patient's not part of that discussion.
Jim, you were there at the inception of the Journal of Vascular Surgery. Tell us about that and whose idea it was.
Well, I was actually treasurer of International Cardiovascular Surgery, International Society of Cardiovascular Surgery, the North American chapter, when John Ochsner invited DeBakey to come to the Joint Council meeting and make a presentation that we have a journal. He made and he actually had a publisher ready to go. And, his sister, Lois DeBakey, was really a phenomenal editor and writer in her own right. And I think Dr. DeBakey was very clear about what he thought would really advance peripheral vascular surgery. After he made his presentation and left the room, and everybody was very polite, most people were a generation older than me. People came out of the woodwork saying, we don't want to have this owned by Dr. DeBakey. And John Ochsner actually agreed with that. So the decision was to contact a number of publishers and see if one of them would be willing to support the journal. And that came to fruition. Jerry Freelander was our first tie with Mosby.
Mosby, yeah.
And the interesting thing is that they gave the title of editor to Dr. DeBakey. I mean, it was really, he was the seed. Mm-hmm. He came in, put the seed on the table, and he left. Mm-hmm. He was never operationally involved with the journal after that. They had two associate editors, Emmerich Szilagyi and Jesse Thompson. And Emmerich, as some will recall, I mean, if you gave a paper, like half the papers at our meeting now, you were in trouble. If you didn't have p-values and have hard data, Emmerich would get up there and scold you. So he was sort of a very rigid person. and he reviewed all of the articles himself. They came to him. Jesse at that time had had some visual problems. He had a retinal hemorrhage, a venous hemorrhage, and had lost vision in one eye and really didn't take part in it. So this ended up being a one-man shop. And Emmerich would finish the papers, make a judgment. He would send a list to Dr. DeBakey of what was going to be published, and Dr. DeBakey would put a stamp on it, and that was the end of it. This was probably a seminal thing for our specialty, it becoming better recognized as separate from everybody else. First place, the journal was half owned by the society and half owned by the publisher. That was not true of the Annals of Surgery, Archives of Surgery, at that time SGNO. You know, they all, SGNO had still partnered that out away from the college. And I remember that when Emmerich stepped down, Kellers and I were asked to be editors. And we would be invited to a consortium of surgical editors around the country. And we were the only journal where we had half the income going to our sponsoring institution, the SVS, that could use it for scholarly purposes, use it to support research, educational things at the meetings, and everybody else really sort of wanted to do that. I mean, Claude Oregon, who was the editor of the Archives of Surgery at that time, said, why don't we take over trauma, and why doesn't the Annals do oncology or what have you? So, you know, the journal really started, you know, on a very fast track with a seed from Dr. DeBakey, but the real workhorse was Emmerich Zalagi.
Under Dr. Zalagi, as a young surgeon submitting manuscripts, you would get back 16 comments personally from him about your papers, and then...
I should comment about Dr. Zalagi's editorial style. I was the only associate editor for a number of years with him, and he would do what I call pick a winner. So he would have two reviewers, say both of them had 10 critiques, and each of the 10 critiques had maybe one or two really important issues. So he would rephrase those and send them back, and the author would address those and send them back to Emmerich. And then there were the others that Emmerich had never shared with the author that would polish the paper up to being a better manuscript and easier to read, perhaps. Not substantive, but important. And he'd have to send it back out to them. And so he would pick a winner, kind of what's the most important thing, and make a judgment about it. And what Cal and I did, and it was carried on by Wayne and Bob Rutherford, they got back everything, even some foolish things that we didn't agree with the reviewer on, but we expected the author to, you know, say it's foolish too, and we would asterisk those that where we thought cardinal changes had to occur, and that, you know, that's a much more logical way of doing things. But Emmerich, and if somebody said, you know, even in advertisements in the journal, you know, this graft proven to be the world's best. And Emmerich didn't want to have the advertisements that way. He felt he was liable. And Arnold Roman at that time was the editor of a New England Journal, and I had discussions with him about how they deal with these conflicts, even with advertisements, much let alone manuscripts that say, I mean, everybody knows this is the first report of this, or the largest series. You can attribute that to naivete of the editor and the author. But when you start making a claim that something's better than something else, then you've got to have some justification. He was very, very particular about it. And to be quite honest, I think he advanced the quality of the journal quite a bit. I mean, you did not get things published. We hired a statistician to review anything where we thought there was statistical data that had to be interpreted.
Jim, tell us about your family.
Well, I've got this wonderful family. I grew up, as I told you, in the mid-50s, the happy days, with a very, very supportive family where everything I did was okay, and what I did that wasn't okay, I never got caught. And a little bit of Irish in me allowed me to get excused when I did get caught, perhaps. My wife and I were college sweethearts. We've been married over 50 years. We've had 3 great kids, 2 boys and a girl. My oldest boy desperately wanted to be a high-tech entrepreneur. Ended up going to Stanford, got 2 degrees there in computational math, computer science and math, computational math. Went to law school after that, met his wife at Stanford, finished up law school at Harvard with her, where she was a law student. They started their first company, .com. They had been offered $110 million for it before the .coms went south, and I kept thinking, sell. And after
Let's get some stock.
Well, I know after and I paid for all of his PhD education, which about 80 or 90 grand a year, and he never defended his PhD thesis, which was on law and economics. But he started this company, and they sold it after the .coms went south. My wife doesn't let me talk about it, but it's a lot more million than I'll ever have. Started another company. My second child is an otolaryngologist. Went to medical school in the Chicago area. Went to ENT out at Iowa. Was on the faculty out at New Mexico. His wife's a pediatrician and neonatal intensivist. And after a while, without any prodding from me, they came back. They're both on the faculty at Michigan now. One in pediatrics department, the other one in the ENT department. And my daughter's a speech pathologist in Gainesville, Florida. Her husband's a geophysicist at the University of Florida. Great runner. I ran Boston with her, ran New York. Got me off the couch when I was approaching my 7th decade of life.
Well, Jim, thanks for coming.
Thanks a lot, Jim.
The Stanley Professorship was established to support the clinical, research, and educational missions of a vascular surgeon in the section of vascular surgery at the University of Michigan, that being the section head of vascular surgery. This professorship was established through generous gifts given by faculty, family, alumni, friends, and grateful patients of Dr. Stanley. The initial recipient of this professorship was Thomas Wakefield, and the professorship was initiated on June 27, 2012.